So, welcome everybody, and thank you for joining. And this is slightly different, I think. I haven't really been involved in very much in these mini med series up until now, so this is a pleasure for me to join. And as you can see, it's probably slightly different from other sessions that you've been attending. And I'm going to talk to you about my role as a nutritionist and how I got to be a nutritionist. And just some of the exciting things, because they have been exciting, aspects to my career, and the variety really. I really like to stress, and if you haven't thought about nutrition as a healthcare career, there's very many different strands to nutrition. And I've been lucky enough to be involved in quite a few different aspects of nutrition, which is what I'm going to talk to you about today. So I'm a registered nutritionist, which means I have this title, and I will talk a little bit more about that as we move forward through this session. So I wanted to really start off with, well, why is nutrition important? There's a variety of different reasons why nutrition is important, depending on your viewpoint, obviously. But clearly, because we're all interested in healthcare, this is so applicable to any aspect of healthcare. But I thought, this World Health Organization quote really sort of sums it up, really. It really relays this message about, how if we all eat well, then we're going to live, a nice, long, healthy life. It's going to help us grow. It's going to help us develop. It's going to stop us from, hopefully, developing other situations. So, it helps build our immune system. There's a lower risk of non-communicable diseases such as diabetes and cardiovascular disease. So that's on the assumption clearly that we all eat well. But you can see, as it says in this quote, all of these aspects from when we're before we're even born onto, older life. Every aspect of our health, is really underpinned here by nutrition. So healthy children learn better. You might have heard about breakfast clubs and so on. But it's really, really important, that children learn about healthy nutrition from that young age, and that then will guide them into older age and develop good habits. So it's really important that, we work with children. But obviously what we also want to see, as it says here, gradually breaking these cycles of poverty and hunger, no matter where we are in the world, because, these situations also happen within the UK, where we are, there are children that are hungry. Those children that live in poverty, are more likely to be living, with hunger, for example. So, that was the global sort of WHO statement as well. But, it's also applicable to us in Europe and, in the UK. But what are the situations that we suffer with in this country or in Europe even, really? Well, as you can see, it's mainly around these situations about poor diet. We do have children that are going hungry, they live in poverty, but for the bulk of us, it is living, and eating a westernized diet, which we know is unhealthy. And the situation with eating, a westernized diet is that it does lead to a large proportion of non-communicable diseases. It leads to overweight, it leads to obesity. And, we're mainly here, we're talking about, a diet that's high in fat, salt and sugar, people that are not moving around very much. They're consuming low amounts of vegetables, whole grains. And a lot of this is associated with that, obesity pandemic that we're suffering with at the moment. And this in turn will have an implication clearly on life expectancy and also quality of life. So, for us in the UK, this is one of the major issues, and as a nutritionist, this is something that is clearly concerning. As I say, we want to focus on children. We want to make sure that we get these messages right for our very young children. They pick up these good habits and they carry this on through into later life. So recently, when I was looking for information around, for this, session today, I wanted to find out, well, what actually are people concerned about in terms of their health care? And, you can see from this Bupa survey here, it's a map of the UK clearly, and you can see that they've surveyed you know, adults really to find out what do they feel are their main concerns around their health. So you can see, I know this diagram's not particularly that sharp, but you can see the pinky reddy colour is where people are concerned about weight issues. The blue colour is looking at, you know, mental health. The green colour is not exercising enough, and there's also a slightly reddy colour that is difficult to differentiate, but there, you know, is also where people are concerned about their diet. So you can see that, you know, this was a recent survey. It says over 3/4 of UK adults have concerns about their health going into 2023. So this was at the start of the year, with worries about weight and mental health being, you know, a big proportion of their concerns. So we know that people are concerned about issues around their diet, around their weight and mental health and so on. So do we then need to worry about that, our weight? So if people are worrying about it, why are they worrying about it? You know, why do they feel that this is a concern? Well, as I mentioned to you, you know, a couple of slides ago, we know that within the UK, within parts of Europe as well, you know, we are seeing this issue around obesity and overweightness. So, you know, actually it is quite a realistic concern, you know, a real worry around our weight and our, you know, you know, whether we become obese or whether we become overweight. So you can see from this diagram here, obesity in England. So this is summarising pretty much from the latest survey, you know, where we are in the country, you know, where we are as adults. So as it says here, in England, men are more likely to have a body mass index measurement above normal than women. And you can see here, you know, when it's broken down, the proportion of, you know, women to men in terms of, you know, overweightness and obesity. And pretty much, you know, the whether you're male or female, it's, you know, a similar picture. And you can see, as it says, around 3/4 of those aged 45 to 74 are overweight or obese. And, you know, again, we can see how that is changing over the years. So this is not just something that we've been aware of, you know, in the last couple of years. You can see, as it says here, from 1993 to 2019, that, you know, overweight or obese, you know, levels of that is increasing. It's still increasing. So, you know, we know that this is a concern. We know then that people within the UK are right to be concerned about their weight. But, you know, clearly, as I've mentioned, you know, this issue around teaching our children good nutrition, you know, being mindful of health, we need to really think about this. And, you know, these are the stats that I find particularly shocking. And, you know, it's something that we all, again, you know, going into this healthcare, you know, as a career, we need to be mindful about how nutrition is having an impact on the health of our children. So, you know, at school, children are measured, you know, when they go in at reception age, so at the ages of 4 to 5, and they're measured again, you know, around about the ages of 10 and 11 when they're in their final year in primary school. So we can see here, you know, if we look on the, you know, with the diagrams where the bars are in purple here, we've got boys and girls again, you know, levels of overweight similar, levels of obesity are similar, you know, at ages 4 to 5. But we can see more worryingly when they get to the ages of 10, 11, again, we've got high levels of, you know, overweight between girls and boys. But then we see that, you know, shifting from overweight into the obese bracket, climbing slightly higher for boys rather than girls, you know, when we get to the age of 10 and 11. And unfortunately, as I've mentioned, you know, children that living in poverty are more likely to go hungry. In the UK, what we see actually is where children are living in deprived areas, they're more likely again to be overweight and obese. So we can see here ages 4 to 5, again, ages 10 to 11, these green bars this time. We can see how living in deprived areas has this effect on, you know, overweightness and obesity. So again, if we look at the most deprived areas, you know, much higher, doubling the rates, you know, in terms of, you know, levels of obesity and overweight compared to those in the least deprived at ages 4 to 5. And, you know, again, that's the same pattern, you know, most deprived areas, we see, you know, greater levels of overweight and obesity in, you know, young children. And these are very young children, obviously at the ages of 10, 11. And we can see again how that's increasing. Even in the least deprived areas, we're seeing an increase in levels of overweight and obesity, as over these years. So it really worrying, to see this. And clearly, if we have children that are overweight and obese, they're going to carry on into adulthood being overweight and obese, because it's a difficult thing to change. A lot of this is tied up around behavior change and habits. So if we can break these habits, or not introduce these habits in the first place when children are very, very young, the likelihood is then that we're going to have healthier children going into adolescence, going into adulthood with less risk of, these non-communicable diseases occurring. Prevalence of overweight and obesity, again, here, as you can see, boys and girls, it's really, really concerning. I guess I just can't stress these issues enough. But, these are the latest surveys. So even though it's showing data for 2018-19 combined, again, we can see that as children get older, that they are getting more, overweight, they're becoming more obese. And, we can see that the pattern is the same in boys. We can see that as they're aging from the ages of 2 to 4, this is increasing. It's sort of peaking around the ages of 11 and 10. And then we see, a little bit of a, decline into that sort of teenage years. But it's the similar sort of pattern for the girls as well. So girls more likely to be, overweight and obese when they get to the ages of 13 to 15. So, this pattern, as I say, from young children into adolescence is continuing. It's what we're continuing to see here. So, obviously, we know that this is happening to all of us into adults. As I say, it's worrying, it's concerning. I'm particularly interested in working with children that are, in that adolescent age group. And it says some more statistics here. The adult age group least likely to be overweight or obese was the 16 to 24-year-olds. And what we need to bear in mind is, why is that so? Because a previous survey to this, was showing something else. So this data here we can see, is showing that not overweight or obese, 72% is what is being self-reported by those 16 to 24-year-olds. But as it says here, when the last measured data was from 2019 was taken, then 37% of 16 to 24-year-olds were overweight or obese. So there's something going on here with the data that's not quite accurate. And it does come often down to this data being self-reported as well. So a lot of ways that we collect nutritional data is by asking people to provide information about what they eat themselves. And that relies on collecting information around, if we ask them to fill out a food diary, for example, for a couple of days, we're asking people to record every single food item over those 3 days. And often what we find, when people are asked to self-report any type of data, they never accurately report that data. You could understand, if somebody was going to go through that data, and look at somebody's food intake for a few days, for example, then, the person completing that diary is wanting to give that best impression of themselves. So they're not going to want to report that they've eaten a bad diet. They want to report that they've had, lots of fruit and veg over, those 3 days that they're recording their data. So it's going to be similar in this case. Anything that's self-reported, unfortunately, we need to be mindful that it might not necessarily be accurate. So again, where we're seeing this from 2019, that 72% reporting not overweight or obese, but we know from previous studies that figure was much lower. And, 37% of 16 to 24-year-olds were being reported as overweight or obese. We can see then that something's gone on in this last measure taken in 2021. So, we have to think, well, perhaps there was something going on at this point, that wasn't necessarily giving us the best accurate data. But I am particularly interested, as I've mentioned, in working with children and adolescents. More so recently, I've become, involved in working with adolescents. And as I say, it is particularly concerning as a nutritionist that, we're seeing children with poor dietary habits, that they're quite sedentary, so they're not moving about much, they're not doing as much physical activity as they should be. So we need to start changing these habits, getting out of these bad habits. So making sure that children are, developing those good habits of eating lots of portions of fruit and veg every day, eating lots of whole grains, eating foods that are low in fat, and so on. And again, it's concerning when we've got data like this that tells us, status of children and young people, so these are adolescents again, teenagers pretty much. 12% reported, when this survey was taken, between 2016 to 2019, that only 12% of that cohort, and I'm not entirely sure of what the sample size here was, the data was collected from, but only 12% of 11 to 18-year-olds were actually, taking 5 portions of fruit and vegetables a day. And that's not surprising. We all know how bad we are at eating fruit and veg a day, but it is quite alarming that it was only 12%. 4% of this age group are only getting enough fiber, and you may or may not be aware. Hopefully you are quite aware, but the advice, nutritional advice, is around eating 2 portions of fish a week. One of them should be oily fish. So average are eating round about 2 grams of oily fish per day, which is nothing. So we're getting this picture of our younger people, our teenagers, that overall dietary quality in UK adolescents is poor. And, this is going to have, as I've mentioned, a knock-on effect as people of this age are getting older. What do we need to be particularly mindful of? Well, again, when we collect data from the public, so there's a regular yearly collection of dietary data from the UK population called the NDNS, so that's the National Diet and Nutrition Survey, and it surveys about 1,000 people from the population, 500 adults and 500 children, and it really is informative for us as nutritionists and for policymakers around nutrition, public health nutrition, for example, because it gives us an idea of what the public, what the general public is actually eating. They are recording this data. There are nutritionists recording the data along with them. So it's not just relying on people to record the data themselves. So this gives us a really good indication of what's happening within the UK, within specific age groups, and we can use that data to inform policy. So, for example, if we know that there's a huge issue around sugar intake, then we need to do something about it. So we do know that there is a big issue around sugar intake, and free sugar is the terminology that we use as nutritionists around the sugar that we add, to perhaps our breakfast cereal or into our tea and coffee, or that's added into foods such as those, when we make chocolate, when we make cakes, for example, we're adding in sugar, and that is called the free sugar that we consume. And this is different from the sugar that we find within plant cell walls, for example. But that within the plant cell walls is going to be broken down. It takes a lot longer within the intestines to break down that sugar. So it's not considered to be as detrimental to health as this free sugar, the added sugar that we have. So, glucose, for example, is considered to be a free sugar. Sucrose, for example, those types of sugars, as I say, that table sugar that we add into our foods. And as you can see here, again, looking at that adolescent age group, we see that, this age group consuming between 9% and 12.5% of our calories from free sugars, depending on the age group. But we know, for example, that within this age group, they are the biggest consumers of free sugar. So the dietary guidelines is that we only consume 5% of our total daily calorie intake, basically, which is, about 2,000 calories, 2,500 for males. So only 5% of that should come from free sugars. So you can see here that isn't necessarily the case, and particularly not so for this age group here, these 11 to 18-year-olds. They are consuming a lot of their calories from those free sugars. And in particular, what we see are these sugary soft drinks, which are those that, still have a lot of sugar in them. So what we know is that we are all consuming too much sugar, but particularly so this age group of 11 to 18-year-olds. And why does it matter? Well, I'm sorry about this picture. It's not the most pleasant of picture, but again, I've used this numerous times when I've, talked to people about, health issues. And what this story basically is telling us is that this was a typical A-level student who was revising, getting ready to take his final exams for his A-levels. And during his revision period, I think it was up to a period of about 6 weeks or something like that. It might have been over a couple of months. I can't entirely remember, but over, a considerable amount of time, he was drinking up to about 45 cans of Monster a week. So, here it says, this is what drinking 6 cans of Monster a day will do to your teeth. So basically this story tells that, this young man was, trying to do his revision. He was drinking large amounts of these caffeinated drinks to try and keep him going so he could, spend a lot of hours with his revision. And he reports in this story that there was one day he hadn't necessarily noted, how his teeth were declining over this period of time. Or if he had noted, they weren't causing him any pain up necessarily. But he reports one day that he'd bitten into an apple and his teeth started to crack and they started to fall away. And he realized, that it is down to the amount of sugar that he was consuming, not necessarily thinking of the sugar. He was obviously thinking about these caffeinated drinks to try and keep him going, as I say. But because they were so full of sugar, it has had this detrimental effect on his teeth. And we know that there is a clear association between sugar intake and dental caries. And we can see this clearly from this diagram. And I follow this up with this story, with this data, which it's been published, in the food manufacturer, so not a high-ranking, necessarily article journal here, but it does give us an indication of what is actually in these types of drinks. These very, very popular drinks that you might be consuming yourself, but you might not realise actually how much sugar is in them. So what we see here is, that somebody had looked at these various types of drinks that you can buy, Lucozade, Red Bull, Monster, Rockstar, and Relentless, and how much sugar was actually in these. And it says that Lucozade and Rockstar were found to potentially have the greatest impact on oral health and obesity. And that's because what they found was this link between the sugar within the drinks and the dental erosion occurred because within the mouth, there's critical pH that the mouth likes to be at, and which is about 5.5. So anything that drops below that is going to have this, detrimental effect, and your teeth will start to decline, the health of your teeth will start to decline, and dental caries is likely to become an issue, the longer this goes on. So you can see here the pH of all of these drinks, is considerably lower than that critical pH. So with Lucozade again being one of the lowest with those pHs, but also having, quite a high amount of sugar in it as well. So, and when I've spoken to various people around about these age groups as well, they all admit, that these are the drinks that they are, they do like to consume, and they consume quite a lot of them. So, it's important for us as nutritionists to be able to, give this information across to the public, because we can make assumptions that everybody knows about how much sugar they should be drinking and so on and so on. But actually, I found that the more that I talk to the general public, the more, people are totally unaware of this type of information and, how bad certain types of foods can be when they're, consumed in excess, for example. So that was just, one indication of, the type of, information that I like to talk about with, adolescents in particular. But also, again, what I've been doing some work in and working with a group of people, some, psychologists and some people that work, in social work and so on, is particularly, again, still focusing on that adolescent age group, but looking at the impact that, food insecurity might have on this age group. And, sometimes we think of, well, how can, we talk about obesity, but then, people that are suffering with food insecurity. So food insecurity is when people don't have access to nutritious, healthy food. So it's not necessarily that they're not having access to food, but it's nutritious, healthy food. So we are seeing this sort of paradox, particularly in this country where people are suffering with obesity, but they're also suffering with food insecurity. So it's access to that healthy, nutritious food. So we're seeing people becoming malnourished again, which I say is this paradox. You wouldn't expect it if we're seeing people, becoming obese, but they're also becoming malnourished, and that is because the diet that they're consuming is not beneficial for health. So, as it says here, while the UK has the second highest rate of obesity in Europe, 1 in 10 children are living with adults who report experiencing severe food insecurity. And again, it's those people that are living in deprived areas are going to suffer most with food insecurity as well as obesity. And obese children in England are more than twice as likely to live in the most deprived areas compared with better off children. And also poor children are also more likely than better off children to suffer with poor health as a result of food insecurity. So this is an article that I, published. So this is a study that I worked with, as I say, with some other colleagues that are, psychologists, for example. And we were looking specifically at food insecurity in 16 to 17-year-olds. There's a real lack of data in adolescence generally, but also, in this specific age group. So we might have lots of data for younger children, and there's been lots of focus around research and nutrition in younger children for those reasons that I've stated, about introducing good habits when children are very young, and then also into adulthood. But there seems to be a gap around this age group, 16 to 17-year-olds. And it's important to understand what 16 to 17-year-olds are eating, or what are the issues around diet for them, or access to good food. And then we can use that information into policy and practice, and making sure that no part of the population is being, left out in terms of, receiving good health care. So this was one of the first studies of its kind to focus on this age group. And we, as it says here, the aim was to identify food insecurity and poor food intake specifically amongst 16 to 17-year-olds in England. And what we found basically was quite concerning. And we found that, we basically recruited a small amount of children, adolescents. I think there was, no more than about 90 people helped us with this survey. So it was a survey that we asked college students to complete. And we asked them a little bit about their diet, about their food intake over a particular day. And also we asked them to complete a food insecurity questionnaire. And what we found was a minority of young people, so out of those 90 odd, a very small proportion consumed enough fruit and veg. So again, this was something we were aware of because we looked at that data before, which told us only 12% of that previous survey reported consuming, 5 portions of fruit and vegetables a day. And the majority of young people consumed 2 or more high-fat, salt, sugar items. So these are, these ultra-processed foods that we're becoming more familiar with. You might be aware of that term at the moment. But the consumption of those types of foods specifically, we're seeing more in those people that reported to be, in that high food insecurity bracket. So we did, as I say, we did a survey around, collecting some dietary data. We also looked at, finding out how food insecure these young people were as well. And this is a typical survey that, with questions, as you can see, asking things about, did the food that your family bought run out? Did your meals only include a few kinds of cheap foods, for example? So it's just a typical survey that asks various questions about food, and access to food. And a lot of the young people, again, reported, as you can see from the, these points here, that food insecurity tended to be characterised by worries about food availability and reductions in food quality, so that less ability to access a balanced meal. So, young people were telling us they had these worries. They gave some affirmative responses to questions on reduced portion sizes and meal skipping. So some students were experiencing food insecurity with hunger. And despite almost half the current sample identifying as food insecure, only 4 young people reported being entitled to free college meals. So we were really interested in this, the access to free, well, not school meals, but free college meals as well. And there was a lack of uptake again within this population of free college meals that shows that the current policy basically is not sufficient to address the food insecurity within this group of people. So, it's important that we do this research to highlight these issues because, we assume when you go to college or you go into sixth form that you're self-sufficient, but, that might not be the case and we can't make these assumptions. So we've since followed up and done a follow-up study here to look at the effects of food insecurity and more specifically around those dietary patterns, because as I say, we were concerned, although not surprised, but we were concerned that some people were reporting that they were going hungry, they weren't accessing, nutritious food. So we really wanted again to follow up and do a bigger study to see if we could understand, what are people of this age group being able to eat and, what can they access, when they're at college. So again, we were looking to determine the effects of food insecurity on dietary patterns and nutritional intake in adolescents in the UK. So we did a bigger study. We're talking about 400 people, so not huge, but bigger than the first 90 odd. And again, what we found was, I guess as we expected, depressingly so. You can see here that we've got, the figure at the top is showing us the dietary pattern of all of the people that responded to our survey. So we asked them to complete a food diary for just one day. We then asked some of those people if they would follow up with a 3-day diary, but unfortunately we couldn't get enough accurate data out of those 3 days diaries to give us any more of an indication than what we could get out of the first day. But we can see here again, so we see a large part of the population consuming sweetened sugar beverages. So these are those monster drinks, Lucozade, those sorts of drinks again. So what they are reporting on drinking, and consuming the most are these types of drinks. So again, we know the issue around these. No fruit and vegetable consumption was the next highest bar. So again, not what we were, really surprised by. Fast food consumption and alcohol consumption came down quite low. And then if we look at the figure underneath, we then wanted to see, well, that was the overall pattern amongst all of the adolescents that we surveyed. But then we wanted to know, well, what was different between these different types of food insecure categories? So we can see those people that are categorized into very low food security, low security, marginal and high security. So those very low ones are those people that we're mainly concerned about because they're telling us that they see themselves as not being able to access nutritious food, compared to those in the high bracket where they're reporting that they are food secure, that they are actually being able to access foods that are healthy. So we can see again that, these blue bars are those percentage of very low participants. And we can see that those blue bars are pretty much the highest in the sweetened sugar beverages. They are the highest consumers of those types of foods. They are the highest reporting not eating fruit and vegetables. And they are also, fast food, consuming the most amount of fast food and alcohol. So, we know that the diet within those people that are the very lowest in terms of food security are the ones that are having the poorest diet. So, the findings from this study, we haven't published it yet. We're still in the process of writing it up. But what we have found from the data is that energy intake was low across, the time that the data was collected across all categories. So we had some people not eating anything on a particular day, but again, not meeting, the energy intakes for any of the, whether they're in high security or low. So, particularly within obviously the lowest group, and, they didn't meet any of the recommended energy intakes. Low fruit and veg, as we looked at as well. But we also know that low fruit and vegetable intake in this age group as well is associated with increased risk of depressive symptoms and mental health across all adolescents. And on average, all food access categories failed to meet the recommended daily total carbohydrate intake. However, all adolescents consumed more sugar-sweetened beverages than they should be consuming. So, it's quite concerning that we're finding this data. And again, 30% of these 16, 17-year-olds took part in the study, reporting themselves as food insecure on that day that they were surveyed. And again, highlights the importance of, providing interventions, so nutrition education to this group of people, and making sure that we can, work with them and work with colleges, the schools, to make sure that people of this age are able to access good, nutritious food. So that's some of the sort of research I've been doing at the moment. But how did I get to this point? This is sort of public health type of nutrition, I suppose. But that's not actually where I started off when I, started on my journey into nutrition. I actually started off as a nutrition scientist, and I did do a lot of work with microscopes, particularly fluorescent microscopes, sitting in the dark for long hours, looking at, slides with cells and, DNA on them. So, what happened? How did I get to this point? And I'm going to try and do this in a nutshell. So this is me, pictures of me when I was quite young, when I was about, 14, 15, I suppose, at the top there, to me when I had my, got my PhD. But, I wasn't a high achiever at school by any means. I didn't come from a family where I was necessarily encouraged. And I'm not saying it was bad in any way, but, there was no drive for, me to go to university or achieve in that way. And I left school, a long time ago, with very poor qualifications, and I didn't really know what I was going to do with myself. So I basically ended up working, in administrative jobs, and I, worked like, in various jobs within the oil industry for about 10 years. But I then decided in my last job that I worked with somebody who said, you know what, I'm going to do a foundation year. I'm going to do an access course. I want to go back to university, and I want to, do something challenging. So she was really inspiring for me, and she helped me, and I decided that I was going to do exactly the same thing too. So with my poor bunch of qualifications, I went along to Aberdeen University, because that's where I was living at the time, and I inquired about an access program to their degrees, and they convinced me that I needed to do a science-based degree. And I thought, I'm totally rubbish at maths. How can I do science? But I thought, well, why not? I've got to give it a challenge. Otherwise, I'm stuck in a job that I'm not particularly enjoying. I need to do something more. So I enrolled on a part-time access course, and I did this while I was still working. I was a mature student at the age of 27, so not particularly mature, but, in terms of university life, it was. I did the access course in health, and I did biology, and I did chemistry, and I did maths, and I managed to pass the required pass mark to get me onto a degree in biochemistry. So that's what I did at Aberdeen University. I did a biochemistry degree, and I was lucky enough to work with this lady, Professor Dame Anne Glover, who actually was very, very inspiring for me. She was a lovely lady, a brilliant lecturer, a brilliant teacher, and totally inspired me and, infused me throughout my degree. And I think it's important, that we all find somebody like that helps us. And she was fantastic. She inspired me to carry on. I decided then that I was, interested in nutrition. I then went on to do a master's degree in nutrition and human metabolism. And even though I was rubbish at maths in my undergraduate biochemistry degree, I found a way to keep out of the lab because that terrified me. And I did a bioinformatics project that, was, again, completely out of my comfort zone, but I managed to do it, and I did it quite well, and I managed to impress quite a few people. And luckily, after I'd finished my master's, I got a job with Food Standards Agency for a short period of time, working as a research assistant there. But it was only a small, short-term contract, and I was coming to the end of that, and I wasn't really sure what I was going to do. But then the Food Standards Agency came back and offered me a longer contract, but at the same time, another university in Aberdeen, so Robert Gordon University, offered me the chance to do a PhD. So there was a PhD looking at working with people with schizophrenia, and I was really drawn to a human study, but it was based around looking at the biomarkers of oxidative stress in models of schizophrenia. So we wanted to understand, how people develop schizophrenia. Is it genetic? Is it environmental? It is a mix of both. But how nutrition can play a role, and can we use nutrition as an adjunctive therapy to obviously treatment for schizophrenia, to see if that was basically going to help reduce the symptoms of schizophrenia and give a better quality of life. And again, I was inspired by two really great people, two fantastic men that helped me, during my PhD. And then when I went on to do a postdoc, I carried on working in this mental health aspect. and worked with people with eating disorders. So it was a fantastic time. You know, I was lucky to work, as I say, with some brilliant people and, you know, really do some fantastic work in areas that, you know, as a nutritionist, particularly working with people with eating disorders, is not something that a lot of people would necessarily get to do. But I was lucky to be able to work, you know, in a project that worked with people with all types of eating disorders and look at, again, some sort of adjunctive therapy to their, you know, their clinical treatment as well. Also, you know, this is a lot of a variety of pictures, but this sums up some of the work, some of the things that I do as a nutritionist. So, you know, the picture at the top there is showing a swimmer in a box, but basically this was a 3D scanner that we used to take pictures in that study with people with eating disorders, so we could show them images of their, you know, of their complete sort of 3D image all around their body. The next picture in the middle there is a bod pod, which measures body fat composition, or, you know, body composition. So it's a you know, a very less invasive way of measuring body fat, compared to the picture at the top there, where I'm using skin fold calipers to measure body fat as well. So, you know, doing different types of methods to measure a similar sort of thing in terms of body composition. Down the bottom here, I'm, you know, engaging this as part of my role now, where I do a lot of outreach, engage with children, but engage with the public around, you know, talking about nutrition, trying to educate people about nutrition and how it, you know, impacts our health. And you can see this picture down on the bottom right. These are images taken from that 3D scanner at the top there, of various people with various BMIs. So again, something we would use in outreach to talk about, you know, looking at different body shapes and sizes and the impact that food and nutrition has on that. The one in the middle, so this is where I've been, you know, spending years looking, using a microscope and looking at images of DNA. So these are showing us different pieces of DNA that have been damaged. So this first image, where it shows like a complete round, like a moon type of image, is DNA that's not been damaged whatsoever, until you go along right to that last image, where there's a very, very small sort of pinhead of DNA, but a big comet tail of DNA that's broken DNA. So this is called a comet assay. This is what we look down the microscope for, to see how damaged DNA can be, but also using things like antioxidants or omega-3s to treat damaged DNA, to see if we can improve, you know, or stop DNA becoming damaged. And that's some of the work that I did with those schizophrenic patients. Part of my job has also been, as well as a nutritionist, is to do some consultancy. And I worked with some other colleagues at Newcastle that were interested in the history of the Newcastle jail that used to be around, is no longer there, but they were particularly interested from a historical point of view of what people used to eat. So they asked me to have a look at a 1875 report, and I did some dietary analysis. So you can see that in the picture there. So it's using some software to do some dietary analysis, and basically to determine, you know, were people that were in prison nutrient deficient, or were they energy deficient, and so on. No surprise, they were energy deficient, but actually the nutrients in some of the diets that were in prisons in these Victorian times were not actually that bad. And people probably going into prison might have come out of prison being a bit more better nourished than actually when they went in. So that, you know, it was a really interesting study. My PhD students now, I have currently 3 PhD students, and again, we're all working in the area sort of with children, with adolescents. One of my PhD students is just about to finish. She was interested in looking at the effects of sugar, not necessarily in adolescence, but, you know, these issues around sugar intake within the UK population. And she's published a couple of papers. We published a couple of papers around, you know, dietary data, but also the impact of sucrose intake on body composition. The diagram in the middle here is, I also work as a consultant with a company called NutriTroops that provides nutrition education and physical activity education to primary school children. And my PhD student now is looking at the effects of this intervention and how it impacts, you know, children's body composition and dietary habits and so on. And another PhD student here is looking specifically at various parts of the population, and she's interested in the Black population, and specifically Black adolescents, and, you know, how they access nutrition information, and, you know, what we need to do to engage with this group of people specifically, and so on. And we found that actually there's no research going on in this part of the population, in young Black males, and it's around nutrition interventions and nutrition education interventions, which again is quite concerning. So we're looking to follow up with that as well. But, so that's a bit of a brief sort of stop, around some of the research I've done, some of the work that I do. But what does a nutritionist, registered nutritionist, actually do? And I thought this might be quite interesting for some of you. Perhaps you've never thought about nutrition as a career before, but perhaps, I've now got you thinking about a career, or thinking about, actually, some of this sounds quite interesting, but what does a registered nutritionist do? There's lots of different areas of nutrition that you could go into. And, these diagrams here show us that there's a range from working within the hospital environment, working within the food industry, working within charity, within research, within sport, health promotion, and so on. So, I've come from working within a lab, within working at the bench, within working within cell culture, within working within people, to all different areas of nutrition. And, basically we can work in a variety of different settings, hospital settings, mainly working, as it says, within preventative roles, but predominantly with healthy people and populations is what a registered nutritionist would do. People that are registered nutritionists can work with patients as long as they are supervised. And that is in slight contrast to those that work in nutrition, but as dietitians. So you might not know the difference between a nutritionist and a dietitian. Well, basically, a dietitian works in that clinical environment and they can work unsupervised. So their degree and their career course is slightly different from, a nutrition degree. So basically they would spend time on placement, working in a clinical environment, and they are then qualified and regulated health professionals to work with people to support nutritional, support, to treat, any sort of, aspect around, disease that can be treated with nutrition. So like heart disease, for example, cancer, so on, as nutritionists can, but generally dietitians are qualified to do this. They don't need to be supervised, unlike a nutritionist would be. So nutritionists tend to work in that, trying to prevent nutritional issues, whereas a dietitian then comes in and treats these nutritional issues, basically, is how we would, describe the two different aspects of this.